Hello and welcome to the Provocateurs. This is the podcast brought to you by the Policy RX Collaborative, the writing group that includes folks like Dr. Andrew Gonzalez, my guest here today. He's one of the collaborators from the Policy RX writing group, and he's going to be talking to us about hospitals and hospital grades, things that you see from things like Hospital Compare or Leapfrog. We're going to talk about these grades and whether or not they really mean anything for you and your family's care. So, welcome, Dr. Gonzalez. Thanks for joining us.
Thank you. I really appreciate you having me on the show.
All right. Now, in the paper, you were talking about grading hospitals, or I guess the way that they're graded right now. They usually get A's, B's, C's, D's, or F's if they do terrible. Can you tell me a little bit more about the grading systems?
Sure. So a variety of different organizations that are involved in quality and safety for hospitals issue grades. For instance, the Leapfrog group, which is the data that we studied, but there are others such as Hospital Compare, which is through the Center for Medicare and Medicaid Services, and then there's health grades, what have you. We looked at the Leapfrog group because they're one of the premier organizations in assessing and improving hospital quality and patient safety.
All right. And what did you find when you looked at their information?
So we found that, well, do grades matter? It depends on how you're grading.
Okay.
So as far as A, B, C, D, F, probably not. But if you look at a pass-fail basis, do people who passed look better than people who failed? Probably so.
Okay, I like that. Because when I was in medical school, it was pass-fail for the first 2 years, and as we all know, P equals MD, right?
That's right.
So is it more like the same thing, P equals this is a good hospital for me, as opposed to if you're a failing hospital?
Absolutely.
Okay. How many of them failed?
Only 145 received D or F grades.
So if you look at the hospitals that passed and the hospitals that failed, were there really significant differences between the outcomes that you were looking at?
Well, for some outcomes there were. We looked at three very important outcomes. The first is 30-day risk-adjusted mortality, which is considered the gold standard of hospital safety and patient and hospital quality. The other outcomes we looked at in the surgical cohorts were postoperative complications, i.e., did the patient have a heart attack after they had surgery, did they have a surgical site infection, what have you. Then we looked at what's known as failure to rescue.
Okay, what's that?
So failure to rescue is the idea of having mortality after complications. Okay. So one way of thinking about improving patient safety is that, well, we don't want patients to have complications, so what we're going to do is just nip that in the bud right at the beginning. The other way of looking at it, although these are complementary, is that, okay, once a patient has had a complication, they don't go straight to dying. Mm-hmm. What the problem is they have a complication, which is known as a seminal event, which then leads to another complication, and eventually the ball rolls downhill.
Down and down and down like that.
Right. So the true challenge and the way to improve mortality is by preventing these domino complications from occurring.
So you're talking about like complication number 2, 3, and 4, not necessarily complication number 1.
Absolutely. We want providers to be able to recognize that a complication has occurred very fast and then be able to have the skill set and infrastructure to deal with it.
Okay, so the better performing hospitals, they actually did better at preventing these subsequent complications?
Correct. So the way of thinking about it is if I'm at a hospital that, say, has a relatively high complication rate and may have a lower failure to rescue rate, okay, I might have a surgical site infection, but it's not going to be something that the next thing I know I have a blood clot in my lung and then I have a heart attack and then I die. Okay. I may have that one complication, but the hospital does a good job at preventing me from dying from it.
Well, when we're talking about surgery complications, isn't it because the surgeon did something wrong?
Sometimes doing it wrong would be a strong word, but I may be saying that because I'm a surgeon. I think a good framework to look at it is that complications and failure to rescue measure two different things. So complication may be some very coarse proxy for surgeon skill, whereas failure to rescue is significantly more about the infrastructure and the ability of hospitals to have teams that work well together and are able to work across specialties and bring all the assets to bear of the hospital to save lives.
Okay, so what you're telling me is that when we looked at, or when you guys looked at these figures and these numbers and looked at the grades, there wasn't really much difference in the way the surgical complications came out from the passing hospitals to the failing hospitals. So therefore, there's probably not much variation or difference between one surgeon to the next surgeon. Is that a good approximation of what you would say, or an interpretation of it?
Right. Well, at the hospital level, between the A, B, C, D, F hospitals, there's not a lot of variation between complication rates.
Okay.
For failure to rescue, there is. The A hospitals did significantly better than the D, F hospitals, and did a little bit better than the B and C hospitals.
Okay, and you're telling me that failure to rescue is more so a hospital issue and not necessarily a physician issue.
Absolutely. At the individual provider level, somebody notices something's deteriorating with the patient at first, but, no person is an island, so it revolves around you being able to marshal the other resources and find other providers that can help augment your skill set.
Okay, so let's go back for a second, because on Policy Prescriptions, which is our online forum, we recently reviewed an article talking about hospital report cards, and we looked specifically at surgeons and their opinions of whether or not reporting their grades would actually make things better. And it was kind of an opinion-based survey. Their thought process was reporting individual outcomes at the surgeon level probably is not going to overall help out with patient quality, but they were okay with reporting things at the aggregate level, like even if it was like a complication score for the whole hospital, just not at the individual surgeon level. So how does that play in with the research that you've done?
Well, absolutely. That's a very good study, and I'm glad that you brought that up. So I would say that the way it plays in with the research that we look at is in the era of increasing transparency and greater use of the internet, patients want a way to determine, how do I find the best hospital? And one of the ways that you can do is to look at, well, how well does the hospital perform? Another way, since a lot of times for surgery, patients choose an individual surgeon, is, well, how's this surgeon doing? So from a methodology standpoint, part of the problem with looking at an individual surgeon is nobody operates enough to have really reliable data. So who knows what this number means? If I flip a coin twice and come up heads, am I a really good coin flipper, or is it a sample size problem? But when you start adding surgeons together and adding all of the other providers that work in the surgical field to provide care to surgical patients together, then you probably can derive a fairly reliable measure of hospital quality that allows you to compare, is this hospital better than that hospital? So the work that we did looked at one of the grading systems that assesses quality at the hospital level to see, well, does it really tell which one's good, which one's not good, or not so much?
Well, we reviewed maybe a few months earlier an article that talked about report cards for physicians also having similar flaws, and part of the big thing was most primary care physicians don't have large enough panel sizes or not enough patients to be able to adequately represent whether or not they're doing well or poorly based on multiple measures like diabetes, high blood pressure, etc. So you'd say the same thing for the surgical side as well.
Absolutely. A lot of the outcomes that we look at are just not common enough that there's enough variation between providers, and providers don't see enough patients to provide that variation either. So we could say this is actually a good thing because people are not dying from going to the hospital as much anymore. But the challenge still is to choose the best hospitals, choose the best providers. So perhaps we need to look at other metrics of quality other than died, didn't die.
But if you're the patient, how do you say, I want to get my surgery done at X hospital versus Y hospital?
Well, it's funny you should mention that. So last week, one of my mentors, Justin Dimmick from the University of Michigan, we actually did a Twitter poll amongst the people who are on the academic surgery list. And I would say, just from my gestalt as to what all the responses were, one way is to ask people who work in hospitals. So I think the exact question was, if you as a surgeon were going to recommend a hospital for your family member to have an operation, how would you go about doing it? And by and large, all of the responses were some variation at talk to the residents who are at that hospital, talk to the nurses who are at that hospital, but basically talk to people who are familiar with the care that's provided there, and what they say should be provided a lot more weight than what we see online.
Okay. And certainly don't get your surgery on July 1st, as we all know in the physician world.
There's some evidence that suggests that's not a particularly good time to go to the hospital.
All right. Well, for those of you that have to go to the hospital, make sure it's, at least in the wintertime or late spring if you have to. If not, you can try to use health grades or Leapfrog, but probably just better off asking a doctor friend of yours where they would go to get surgery if they had to go. Thanks a lot for coming to visit. Hopefully we get to see you again sometime in the future.
Thank you so much for having me.
All right, thanks for watching the Provocateurs.